We move on to the next talk by SALVIN, Predictive Factors for Success in Scleral Buckling Surgery.
Thank you very much for APO and the AIOS for giving this opportunity. I have no financial interest to disclose, so let's move forward. Well, the retinal detachment is most of the time, the primary detachments are treated with nowadays with vitrectomy, but buccal has a major role to play, and it works by altering the transvitreal tractional forces and promotes the retinal healing or attachment by displacing the fluid under the retina. And anatomical, the success is actually, there are two components, anatomical reattachment as well as the meaningful visual vision gaining. Now, if you look at the literature over the last few years, few decades, and there is still a major place for the major place for the scleral buckling in primary retinal detachment in the treatment. But the fashion is by many vitreoretinal surgeons is to move to the primary vitrectomy for even sectoral detachment. But recent two meta-analysis explain that the difference between the primary simple retinal detachments, the treatment, there is no big difference between the two modalities, but when it comes to the cost and the complications, scleral buckle is still superior. The advantages of the scleral buckling is preserve the vitreous and the lens, and it reduces the risk of cataract and the glaucoma, no need of tamponading or positioning, and it is cost effective. And especially it is very important in young patients without PVD and including the myopic patients. And predictive factors are important because it guides a selection of the patient and optimize the patient counseling. And these are the predictive factors that you can determine whether it's going to be successful or not. If you take the extent of the retinal detachments, as the previous gentleman told, if it is a focal or a subretinal localized detachment, the buccal success rate is very high rather than going into vitrectomy. And like in the previous videos, giant retinal tear has a poor outcome if you start in buckling. And there are many articles to prove that. And age is an independent factor that it relates to the success rate of the scleral buckling, and younger the patient without PVD, more success rate in the scleral buckling alone. But if you come to the older generations, vitrectomy sometimes prefers. And the lens, of course, has an important factor. But if you consider the pseudophakic detachment, we have the concept that we think the cataract surgery increases the risk of slightly risk of retinal detachment, but it has not been proven now. According to this recent article, the phenotype is different between the two groups of retinal detachment. In fact, pseudophakic detachment and the cataract patients have detachment totally different from the phakic eyes. Therefore, it is important. The other thing is the visibility of the difficult in pseudophakic detachment when you are doing. And in 2012, by Arsak et al., this in Turkey explained the chandelier light system. You can easily use the chandelier light system, and that prevents difficult visualization of the buccal, exact localization of the buccal, and then you can insert into the buccal in the proper place. But the issue here is, it is also not without complications. It can induce, increases the complication rate of endophthalmitis as well as the lens touch during surgery. Now, if you see this way, you can easily locate the small tears, and exactly you can put the buccal. But sometimes because of these lens, patients with lens, otherwise difficult for you to identify the place. Now you can mark the place and nicely put the buccal here. So then you can remove it. And the ocular conditions, other ocular conditions which important in considering the scleral buccal is glaucoma. And it has been shown that the primary open angle glaucoma or chronic open angle glaucoma is more common in vitrectomy group compared to scleral buckling. The reason is they consider that because of the oxygenation of the retina induced a cascade of events that causes changes of the trabecular meshwork and lead into glaucoma. And epiretinal membrane and the macular edema, if those things are there in preoperatively, it is better avoid as much as possible vitrectomy. But epiretinal membrane, if it is thick, of course, it has to be removed. You have to do the vitrectomy. Otherwise, if you do the buccal, the progression of the macular edema and ERM is less. And narrow angle patients and the myopic patients, of course, the buccal is superior because the chances of getting glaucoma is less in these patients in vitrectomies if you do the vitrectomy. But the risk factors, pre-existing narrow angle, high myopia, and placement of the encircling band anterior to the eye equator can give rise to angle closure glaucoma in buccal. Now, this patient is Seychelles, coming from Seychelles, young patient, 22-year-old. Patient had LASIK surgery 1 month after, coming with bilateral inferior detachment. I did the both eyes buccal because macula was on an inferior detachment, and the patient complained severe pain and vomiting few days after. To see that if patient has got a in the right eye impending retinal vein occlusion, which fortunately it was none. Over the phone I prescribed Diamox acetazolamide tablets, but after a week, because the patient's pain reduced, patient didn't come up until 1 week. When the 1 week I come, it has almost resolved right eye vein occlusion. That is a very important thing because of the buccal. Sometimes you can induce very high eye pressure, which can lead to angle closure glaucoma. This is more common in the myopic patients. But in myopic patients, I agree with many speakers previously, it's not easy to do the retinal vitrectomy because the removal of the vitreous hyaloid phase is not easy. And if you can manage, especially with the inferior detachment, if you can manage with buccal, I think that's the best option that you can have rather than going into the vitreous cavity. That's better. And if you have proliferative vitreoretinopathy, it is no option. Best thing is to go ahead and do the vitrectomy. Buccal is not a good option. So systemic diseases like most of these patients, especially old age, they have on heart ailments and then they have on antiplatelets, and in that case often safer for the vitrectomy rather than going into the buccal. In conclusion, key predictive factors: extent of the retinal detachment, patient age, lens status, and ocular systemic condition, and myopia, PVR are very important in considering the buccal selection of the patients. It's buccal. Thank you.
Thank you very much, Nevin, for giving a very good talk on buckling. And in fact, buckling, we are happy, at least I, being an old-timer, that it has come back and more people started again doing buckling because we realized that if we are going to do what you have already talked, and what used to happen that the hyaloid can't be removed in younger patients and they come with PVR and proliferation later on. So I think with this many studies coming where they have shown equal or better results with the lesser complication, so it's again for younger people that they must learn even today's time indirect ophthalmoscopy as well as buckling. So don't let it go as it appeared some time back. Yes, please, Tariq.
Yes, sir. I was just echoing with you that still I feel that scleral buccal surgery is a 5-day test match for me, and it is classical. And this vitrectomy, this is one difference. The retina will be definitely attached. But my question to Dr. Selvan that yes, during this selection of that tire, that is which usually you do, that 277 or 287, which one you are using in your practice? Say in my practice, I am using basically 277, that is 7.7 millimeter. What is your experience in your setup?
Yeah, I also use the 277 bands, but in that case, I use the sponge because that's a very localized detachment in the video, so that I was able to manage with the sponge, but I prefer the 277 solid silicon bands.
That is, and also encircling 2.5.
Yes, I often use encircling bands, especially the PVR cases, total detachment.
And also cryo to the break.
Yes.
And subretinal fluid drainage.
Well, if you use the encircling band, I don't do the cryo because encircling band are usually combined with the vitrectomy. If you need to do the encircling band, it is in that case it is better for you to go and relieve all the tractions and then do the peripheral laser and then come out with tamponading agent rather than depend on the encircling band alone. But I put encircling band sometimes in pediatric ROP cases, without going into vitrectomy.
So basically, I think most would use, as Tariq said, 277 and 240 as far as the primary buckle is concerned. So that is mostly more popular, and most of the buckleable RDs can be handled that way. Once we are going to multiple brakes and issues with the posterior brakes, I think we are not going to those fancy other buckles which we used to do in past, because I think that advantage we have at this time. So thank you very much.